Great. Thanks, everyone, and welcome. We're talking today around the LTC Recovery tool. The name on the slide is slightly different. The name on the tool is slightly different as well. It has had some difficulty in finding a name for itself. But this is the recovery tool and also the recovery approach. We're going to go through some slides to give you a background, go through the tool, and have some time for some Q&As as well. My name's Chris Carvalho. I'm the GP in Debugger Surgery and also CVD clinical lead and clinical lead at CEG. We've got Jo and Luis with us as well from CEG, who are helping support. And if you have any questions, either direct them through to myself ideally or to Jo or Luis as well. So let's kick off with our slides and then give you an overview of what we're talking about. So hopefully you can see that. That then gives you an overview of the tool and the approach. And the reason I'm talking about an approach is that this is something which doesn't sit by itself. And within primary care, we all do long-term condition recall and management, and we all do that very differently. So it's not a one-size-fits-all approach to everyone. And this is really about using tools that fit within your own practice and how you work to help make it as easy as possible for you to manage your own patients. I'm very conscious of being a jobbing GP that the workload in primary care is significant. It's probably the worst I've experienced in my time as a GP. And it's something that we need to think about how we can work well with the tools available to us. That then means about thinking about how we identify patients who are at most need of our input and to prioritize our workload as well. Alongside this, we have a wider team with our additional roles, with many of us having pharmacists working in our practice. And so there's an option then to delegate some of this to our wider team. And that could be our data analysts, our practice managers, our nurses, our admin team, our receptionists, and our pharmacists as well. What we want to do then is embed self-management and remote monitoring as well to help with that approach so that we're not all doing it, that patients aren't solely reliant on ourselves. But when we're thinking about the patient, often we do our recall and we recall an individual condition. And actually what we should be doing here is thinking about the whole patient and thinking about how we do a holistic recall. It works similarly to the existing Apple tools that CG have developed in the same way of running the searches within EMIS and then exporting the data. And we'll go through that in a bit more detail shortly. This is what you will first see when you open the tool. It may look slightly different with the new iterations that we've got, but in the essence, this is the same as the others as well. The first thing to do is to run the search within your practice, within EMIS, and export the data. And all of this information will be in the guide that we send afterwards. You click the folder icon to locate the CSV within your desktop, and that imports it into the Excel spreadsheet. You then click the start button to process the data, and then underneath where it says filters for stratification, this will then populate. So I'll come on to that in a second. Just between where it says start where data is cleared and reset to clear, there is a new button, which is the export to Accurx, like you've been doing with your vaccine recall. You can now export lists of patients to have a recall through through Accurx as well. The first thing to do, though, once you've done the searches, is to set up your team. Think about who's going to be your analyst, who's going to be doing the recall, who's going to be your phlebotomist, your nurse, your doctor. There's also a pharmacy there as well, and put them email addresses in, and then change your practice code to your own practice. You can see here there are 8 main conditions we are looking at, and that's CVD, so ischemic heart disease, angina, AMIs, strokes, TIAs, peripheral arterial disease, looking also at AF, asthma, COPD, diabetes, heart failure, hypertension, and CKD3, and also patients who have SMI. And then it looks to see whether they have dementia, learning disability, whether they're housebound, and whether they have long-term conditions, and also the number of long-term conditions they have. the deprivation score, frailty index score, ethnicity, and then these major factors as to their condition, the blood pressure, the HbA1c, the dates of those, and the dates of their reviews as well. So this sets out the formation of the team to implement and support the call and recall. This is the team approach. It shows the current performance, which can be filtered to specific conditions and by control of LTC. I've mentioned on there the HbA1c, and actually we're using the newer calculation, not the percentages. We can also filter by the date of their last review. So if it was more than 18 months ago, you can see all those patients who haven't had a review recently. And it also allows the population breakdown of those with long-term conditions, the number of long-term conditions, the ethnicity, the deprivation, housebound, etc., etc. That allows you to allocate your team and add their email addresses, and it gives you the instructions for the entry of the EMIS search file. The next page is the patient view page, and this gives you the overall view of the individual and those long-term conditions and the major indicators for them. I'll show you the updated version on the next on this actual spreadsheet, but this is just to give you an overview of all of those conditions that you've got: the AF, asthma, COPD, diabetes, heart failure, CVD, CKD3, hypertension, and then the major factors within that. The main bar has the main LTCs, and each one only appears if the patient has that condition. And then those values are color coded by RAG rating where relevant. So they would have their blood pressure, the cholesterol, the lifestyle data, the BMI, the immunization underneath that. The main medication is linked to the conditions and the latest bloods. This is probably a closer look to see what it looks like there. So you can see from here on this individual, they don't have anything in the diabetes box, so that goes blank. I'll show you a better example when we go live. The next page is the population view page, and this gives you the overview for your practice long-term condition patients. It gives their names, date of birth, all of those demographics, the conditions they've got at high level. Or it doesn't give you the direct code, it gives you CVD or AF or hypertension, and then all of the different indicators. One of the major factors within the tool is the recall, and there are three main ways to do this. Firstly is with the Accurix button, which we've talked about, where if you filtered, you can then send a list out to a CSV file and then share that with colleagues or input that directly into the Accurix recall. So, for example, you could recall everyone to have a blood pressure check or to fill in their asthma ACT score. The other method of doing this is through the questionnaires. So there is a setup in there, which I'll go in again in a bit more detail, to be able to send an individual a one contact questionnaire to review that condition. One contact, which I'm hopefully you're familiar with, but if not, we can send you the details of how to get set up on that. But one contact has been described as Accurix Flores, but on steroids. Not my words. This is how it's been described to me. They're like the Accurix Flores. They allow the patient to enter in details, but it does much more detail, and we're allowed also to make them bespoke. Although Accurix have some ability to make some custom ones, they don't necessarily have the complexity that we need for our questionnaires. And the final way to do the recall is through an Outlook email. So by selecting the person that you want to email, you can then send them a list of the reviews they need and the blood tests they need to have done. You can either send them that email or you can copy the text and then put that into a EMIS task. I'll show you how to do that in a sec. So you can do the stratification from that front page. You can also do it from the population view. The population view has much more to look at to stratify with using those drop-down lists at the top of the columns. And you can select by just whether they've got entries in there or ranges or dates, etc. You can then generate this list, which will then you can export using Accurix, or if you want to just using the normal Excel ways, and it allows you then to focus on your particular cohorts at a time. Within the practice, and this again as a suggestion, what you can do is run the search monthly and then input it into the dashboard and do that analysis, perhaps as on the basis of an MDT approach within the team, within the practices within the team, to decide who needs to be recalled and what happened with those from the previous month. This is the practice approach, and the practice knows the population best. This isn't something I'm aware of. I'm not going to tell you you need to focus on this population for this reason, because it's really down to your population. There is some guidance out there, and we can advise on which groups to focus on, but really it allows the practice to understand who needs to be prioritized. The other option is, and perhaps coming from January, you could run this as a weekly search by the analyst, who then allocates recall to the different team members. This allows you to embed remote monitoring through those questionnaires and engage with patients to manage the condition and give them the greater control. There are going to be possible adaptations to develop the tool based on your feedback, and that hopefully will include some wider lifestyle factors and also some wider determinants of health. The key, though, is this is a holistic approach, utilizing not only the whole of the patient but the whole of the practice in relationship-based care, so that I can select who a patient is recalled by and who sees based on who we think they know the best or who their preference is to be seen. It doesn't have to be with myself. It doesn't have to be within with the nurse or the pharmacist. It could be whoever the patient needs, feels more comfortable to see and speak to, and then based on their ability to manage that condition and do the recall indicators. There is some thought about the tool being used at population health level wider in the practice, and we've had some discussions about this being run at PCN level and used for other tools, for example, within the anticipatory care team. But really, for you, it allows that analysis and insight of your patients who have LTCs, for the management, for the risk stratification, prioritization, or understanding just of your population. And one of the key things which we'll demonstrate as well, which fits into the LTC contract, is it allows some inequalities analysis and understanding, and some work to focus on with that LTC contract with the inequalities indicators. I'll stop there sharing that, and I'm going to come on to the actual tool. So this is a demo version. It's a slightly older version of the ones I had before. Just lost that for a second. Bear with me a sec. There we go. So this is a view from the previous version. There have been some slight updates which I'll go over shortly. So you'll see in here, yes, you've got the folder icon there to locate the CSV file which you've saved to your desktop. Then you've got the green button to process the data, and then this is the Accurix button there, so you can send that to a CSV file in Excel. So you can either email that to a colleague, you could to do recall, or you can put that directly into Accurix then to send out send a text message. These email addresses can only be put in as nhs.net email addresses, because you'll be sending them confidentially information. So we don't want you to be sending that to Gmails or Hotmails. That's your practice code. That's the over at the moment, so please change that. That is relevant to the one contact questionnaire, which auto-populates the text string. So you need to put your practice code in there for it to come back to you as a practice. So I'm going to give you an example of how you could use this. So you have the filters for stratification here. And in the LTC contract with the inequalities indicators, one of the 3 inequalities indicators is to look at the population who have hypertension, who are from a Black background, whose blood pressure is above 140/90. So what you can do is come along here, click on hypertension, click on the ethnicity as Black or Black British, and then with the blood pressures, you hover over them and it will come up with the value. So there it says 140. So I've clicked, held down the cursor, the button on the mouse, and then sliding all the way across, and that will select everyone who has a blood pressure of above 140, who is Black and who has hypertension. Then you go along to population health view, and you can see here, this is your population who fit that criteria. So they are black, they have hypertension, and their blood pressure is above 140. On that, you can see that these are RAG rated. So they're on there in column W. You can see you've got a blood pressure of 140 or below, which is green, a blood pressure of between 140 and 150, which is yellow or amber, and then above 150 is red. If there isn't a value there, then that's black. You can search then, and you can refine in greater detail by clicking on that arrow at the top. So that little button there, the funnel at the top, you can go down to number filters greater than or equal to, and you can say I only want to focus on the population who, for example, have 160 or above, and that will refine it even more. But what you also then might want to do is think, well, I'm going to just send out a text message to this patient, and this patient, but for this one who has multiple long-term conditions, I want to see what else is going on with them as well. So at that point, you then come onto the patient view tab, and you'll see that individual. You'll need to select from the drop-down list, but then you'll be able to see all of their indicators. So we've got a dummy patient here. These are all not patients' names and details. So these are all fake patients. But this patient, see the name, gender, date of birth, age, EMIS number, ethnicity, a number of long-term conditions, their IMD score, whether they've got SMI, LD, dementia, the frailty index score, and whether they're housebound. And it then has those long-term conditions at AF, asthma, COPD, diabetes, heart failure, CVD, CKD3, and hypertension, and an SMI as well. And then the indicators underneath that we've selected, and the number of and then these are rag rated as well. So if you select a different patient, to this one, you'll see that those other things that they don't have disappear. This patient only has asthma. They don't have SMI, they don't have LD, they're not housebound. Those things have disappeared. So it only shows you the information that is relevant to that individual. If we take one of the conditions, so if we say AF, this patient has AF, so you want to know their CHA2DS2-VASc score is above 3, and that suggests that you need to have a look at their anticoagulation. They are on an anticoagulant or on warfarin. But also you need to look at their blood pressure and their statin and when their last review was. In that, the last review was in 2015. That's more than a year ago, which is why this is red. If it was more than 6 months ago, it would be amber. If it's within 6 months, it's green. You may then decide that they need to have a review. And so you would come on here to the recall button, click the drop down, and select AF review. Why is that important? Well, if you come over then to where it says team member email, you'll see there's a drop down there which says the recall, analyst, pharmacist, phlebotomist, nurse, and doctor, and that takes the email address from the front page. So what you can do then is say to the recall person and click the box below it, which should say email to team member. But if you click that, that will open up the mail provider you have, normally Outlook, and it will extract the reviews they need, the medication, if they need the medication review, and the blood test they need. So this person needs to have an ACR test done, which you've selected. That will then populate a email to the person that you've selected here. It does not click send because you need to see whether or not you're happy to send that. And actually, you don't have to do this through Outlook. You can copy the text in there and paste it into an EMIS task. So then you could do the recall through there. So that's a different way of doing the recall. I mentioned around the questionnaire. If you click on the questionnaire under the box, if we're going with asthma, if I click on here, if I copy and paste this, I can then, if I copy it, I can paste it into Accurix, and it will send them the text message string that will then invite them to fill out the one contact questionnaire through the link. So all you have to do is Control C and then go into Accurix and Control V, and that will put that into the text message. So you've got AF, asthma, the different things on there. The asthma, you've got the control step, you've got the ACT score. This is just putting the data out from EMIS. And similarly with the salbutamol issues. The salbutamol issues is the number of times salbutamol has been prescribed, but not the number of inhalers. So it's important with all of this is to make sure you have EMIS open alongside it. EMIS is the Bible. EMIS is the reference point, the one that you will need to use. That gives you all the information. But this allows you then to have that view as a whole, but refer back to EMIS and the record so that you've got all the right information on there. So we've got questionnaires for asthma, COPD, diabetes, CVD, CKD3, hypertension, smoking and alcohol as well. And as one contact adds more, we'll add them in as well. So on this, yep, so we've got the medications as well. It will pick out when that medication review was last done. And you'll see on this that there are different dates for the reviews. So the AF review was done in 2015, the asthma review was done in 2022, the medication review was done in 2018. This only picks out the review code for that condition, and different practices work in different ways. So it's important for you to understand how it works in your practice and what you are looking at and what these means for yourselves. So ignore them if you don't use an AF review code. If you do, then great, so it will be pulled out. But it may be an opportunity for you to have a think about how you use that. One of the things that we are looking at and interested in terms of risk stratification and prioritization is the workload that is involved in recall. So as part of the end of year review, what we will be looking at is the number of times that you have recalled a patient. So with that, there are certain codes that this will pull out around chronic disease management. With QOF, it would be ideal to be able to pull that out as using the QOF review codes, but unfortunately, the complexity there means that it is better for us to think about using a simplified approach, just identifying the number of times you have recalled a patient, once, twice, three times, and the dates of that. It's helpful for two ways. One, about the end of the year reporting, but also for you to have a think about when is the appropriate time to recall an individual. If you've seen on there that this person needs to have an AF review or an asthma review, but you've already recalled them on the date in the last week or two, you may think, well, I'm going to hold off recalling them again and give them a chance to come in. Or you may think, well, it's been a week or two and they haven't responded, so I am going to chase them up, maybe send them a text message, etc. But it allows you to understand how engaged they are and how much you need to change your approach to trying to get them to engage with their long-term condition management. I think that is pretty much everything on there. I mean, it's just to say that the blood test results are there as well, and you can select which bloods are needed. It allows you then, when you do the recall using the email, to tee up the appointment so that you can book in the appointment with the phlebotomist, and then a week later book in with the nurse or the GP to go through the results. But allows you to coordinate your recall for them. And also, it allows you to say for your appointments, I need to have not just their diabetes bloods, but their cholesterol, their ACR done, all of this done together in one. And also for their recall appointment, their AF, their asthma review, all in one. I mentioned around some of the lifestyle indicators that are down here at the bottom. That's your immunization, smoking, alcohol, your others as well. More for information, but that's helping hopefully to understand what you're looking at. You can also, sorry, one of the other differences in the newer version is the frailty index score. So there's a slider down here at the bottom of the front page, which will show you the slider of that index score. It relies on practice having processed that and put that in, but it also pops up here on the top right, so it says the frailty index score up here, and that's for you then to interpret as well. I'll pause there because I think I've covered everything that I wanted to discuss, and let's see if there are any questions, and we can go over some more bits in the detail if you see fit. Jo.
Chris, mine's not a question, but it's just really to flag up about the LTC contract. I don't know if you said this at the beginning, but using your risk stratification tool, it's one of the tools, isn't it, that practices can use as part of the risk stratification part of the LTC contract?
So the currently with the LTC contract, there is a part of the contract is geared towards using a risk stratification approach. Decided by the practice, and this is the one of the main ones that we are using amongst others. And then at the end of the year, there will be a reflective template to understand the approach and how that has worked or not worked. Now, this is for two-way approaches. It's both for us as a practice, sorry, as a borough, as a place-based partnership, to understand how this has been implemented, how it has worked or not worked, what the learning is there, and to think about how that then forms the future plans alongside how this has worked on particularly those who are hard to reach and how it has impacted on the inequalities indicators, of which there are three. There is one looking at the at-risk of CVD population who are Black and who have been prescribed a statin. Then there is the housebound population who have diabetes, who have had a full review, and then the as the one I described, the patients with hypertension who are Black, who have a blood pressure of above 140 over 90. So at the end of the year, just after the 1st of April, we'll be asking you to complete a reflective template to give us your perspectives on the recalling those who have not engaged previously, the methods, the tools, the approaches that you have used, so that we can share that amongst each other, but also use it to help us guide how we move forward on that. Jo, does that answer your question or your comment?
Yeah, thank you.
Shane, did you want to comment on this as well?
Yeah, hi, thanks, Chris. And yeah, it's great to hear about sort of how the tools progress with additional features. And I know practices are using a number of risk stratification tools this year and testing those out. And of course, we're keen to hear sort of how they're using them and how sort of successful practices are with the approaches they're trying for those populations. I think one of my questions just around one contact and specifically, and sorry if I missed the beginning, is it now fully integrated with EMIS so that just like with ActRx, you can directly save into the notes and save all the coded information into the notes just at a hit of a button, or is it not as simple as that yet? Because I know that was one of the...
It is fully integrated now. So with the information through the one contact questionnaires, that will come back as coded information. And the same way to ActRx, if it's a case of clicking save to record, and then all the information that is coded and otherwise will come into the GP record.
Oh, brilliant. Okay, because that was one of the things that we definitely got as feedback from practices through the remote monitoring stuff, is that, the sort of the more integrated it is and the more usable it is, the more likely practices are to be able to adopt these things. So it is the same now. It's just that there's a little toolbar type thing and we can just save it into the notes.
Yeah, so there is a slightly separate platform that you will need to log into on a regular basis. So it's important that somebody within the practice has ownership of that to make sure that they are looking at that. Similar to the way that many of us work within our recall for ActRx, there's an individual that looks at the practice messages that are sent out on a regular basis, that then gets added to the record and an individual notified about that. So again, it's about how the practice works and how the practice is set up to take this on, and thinking about how this fits in with your current approaches. Any other questions or comments from others? Is everyone happy with the functionality and how to use it? I think one of the things is to be able to have a play around with it so that you can get better understanding. And one thing I'd hope to be able to do then is a follow-up webinar like this, so that we can go through in a bit more detail and have more questions, probably towards the February time, before the run-in for the contracts. I don't see any other hands or comments. Okay. As I said at the beginning, we had an hour for this, but we didn't need to use a whole hour for it. Hopefully you've got the detail there. But we've all got your email addresses now, so we'll be following up afterwards with some support and guidance and the information that I suggested we'd send at the beginning. If you do have further questions, you can contact myself, Lewis or Jo, and we can hopefully answer those. But we'll be in touch with some further details. Unless there are any other further questions, we'll leave it at that today, and I'll allow you to enjoy the loss of the snow.
Thanks, Chris.
Thanks, everyone, and take care for now.